We are going to be talking about how to face the sizzling world that we all occupy. But just to set the stage, we are in a horrific time in terms of heat. And it is very clear, and I don't think you're all probably very aware, but we cannot stop talking about the increasing heat that we're facing in the world. It is a massive mental health and health threat. And just as we meet now, Europe is sizzling under record breaking heat with deaths that are already occurring. It's still springtime, and we're having these extraordinarily very hot times. In San Francisco, we had 88 degrees, which is really very hot in San Francisco. And I know Bob Fetter, who is here, also complained of extreme heat where he was in New Hampshire. 2024 was the warmest year on record. And 2025 was only slightly less, and due to the modifying impacts of La Nino. What we will face next year with El Nino is still to be faced. It will be very very hot. And these are life-threatening events. We cannot and we will be continuing to face discussions like we're having today, probably on an annual basis, to keep this fresh in our minds and help us to how to survive this. So Giselle, could you go back to the first slide? And I just want to introduce our panelists, who I'm delighted to welcome here tonight. Our first talk by Alexander Levine will be on the overview of heat harms. And Alexander is just beginning his first year psychiatry residency at Gateway Community Service Board in Savannah, Georgia. And he's just now graduated from Lincoln Memorial University DuBuque College of Osteopathic Medicine in Tennessee. He's been involved with our early career network of Climate Psychiatry Alliance since 2023, co-presenting with me on the relationship between environment and mental health for Louisiana State University, Baton Rouge Grand Rounds, and he's also presented at the American Conservation Experience. His interests include social determinants of mental health, lifestyle medicine, and interventional psychiatry. He is one of our up-and-coming stars in CPA, and we're so lucky to have him here tonight and in his ongoing work with Climate Psychiatry Alliance. He'll then be followed by Shui Wei, I hope I got the name properly. They is a sexual health doctor at the Imperial College in London and a leading advocate for the intersection of how climate change impacts human health through research, education, policy, and advocacy. From founding healthcare students for climate action during their medical studies at the University of Leeds to researching the link between extreme heat and severe mental health at the London School of Hygiene and Tropical Medicine, their work strives to use innovative ways to communicate climate health. Whether speaking at festivals or global platforms, such as the Planetary Health Annual Summit, they are committed to empowering the next generation of climate health conscious professionals. Shui thinks out of the box and will share some of their creative work in bringing our attention to the heat harms of schizophrenics. And we need to really welcome Shui. She is in London, and this is the middle of the night for her. So we are lucky to have her up. She's already told us she'd had a cup of coffee. Robert Fetter is our last presenter, and he'll be expanding on the impacts for psychiatric populations. Bob has had a career that has taken him into many aspects of behavioral health, from organizational leadership to direct care in areas of substance abuse, mood disorders, and forensic psychiatry. Bob's been involved in many aspects of climate mental health, serving as the American Psychiatric Association representative to the steering committee of the Medical Society Consortium for Climate and Health, chairman of the Behavioral Health Work Group for the New Hampshire Healthcare Workers for Climate Action, treasurer for 350 North New Hampshire, and activities with No Coal, No Gas. And from my point of view, the important leadership role of Climate Psychiatry Alliance, he's on our steering committee, where he always steps up where needed, from testifying on policies, speaking to many audiences on behalf of Climate Psychiatry Alliance, to his talent as host of our author and book club discussions, and much more. And then I'll give some wrap up comments on things that we can do. Next, on to Alexander.
Thank you, Dr. Cooper, for that introduction. Look forward to a good talk today. Just a second as I get to sharing. Okay. All right. So to start us off, I wanted to have a brief discussion about heat harms, both how they're experienced and how they manifest. So I think in reflecting on just generally talking broadly, what is heat? I think that we can all agree we have like a sensation in mind when we first think about heat rather than like a Webster's dictionary definition. Talking about heat as a form of thermal energy, we can measure this both in our environment as well as in our bodies. We have thermostats, we have thermometers. Yet everyone experiences heat differently. This is going to be a common theme. Each of us has a different threshold for our heat tolerance, and this is influenced by our environment, our biology, and even our cultures. So the difference in heat experience can, as I mentioned before, be related to the environment. Not all heat is the same, and it's influenced by a number of factors such as our humidity or our wind speed. In the case of humidity, obviously, to take, for example, 97 degrees Fahrenheit, which should be a standard number, it's an objective measure. It's very different when you're looking in Arizona versus when you're looking in Louisiana. This is a contribution because of the wet heat, which really just describes a higher percentage of water vapor in the air. Important to this slide is that water, really in any form, including these vapor particles, will trap heat. So when the air is already saturated with this vapor, our sweat, which is a main cooling mechanism in the body, will not evaporate as quickly. The less evaporation, the greater the perceived heat. Wind speed, similar mechanism. We have this speeding up evaporation by really circulating the air and also speeding up the evaporation of our sweats, our thermoregulatory measure. Then latitude and altitude, interestingly, they're inversely related to heat. As we both increase in latitude and altitude, the relative heat will decrease. And this is due to the hair receiving and holding less heat, respective to both latitude and then altitude. We then have mitigating or protective factors, such as our bodies of water and greenery or shade. Water, as I mentioned before, will trap heat. So the larger the body of water, the more thermoregulation that we experience. Additionally, green spaces not only offer shade from the direct thermal energy of the sun, but they can also cool the nearby environment through a process of their own water loss through foliage. It's almost like their form of sweating, and their vapor that they produce similarly can trap heat and expel it into the environment. That being said, a lot of our green spaces are disappearing. They're being replaced by urbanization and destroying our natural environment. In the case of asphalt and concrete, they are not transferring they're not dissipating the heat as effectively, and rather, in their own way, trap it, causing a local heat island. This is increasingly an issue and disproportionately not only impact inner city populations, but also poor communities due to this inequitable urban planning. We also want to really focus on this when we talk about communities that are disproportionately impacted, because we also see this as a demographic pattern within communities of higher minority population. So, as I transition to the next slide, we've already mentioned sweating as one measure of heat regulation. However, our body also has a number of other tricks to keep us cool. Uh, this is all really routed through a part of the brain called the hypothalamus, which interprets our sensory inputs and translates it into outputs, whether this is autonomic or uh, not perceived by our mind. We don't have to think to create these effects in our body, or through our behavior, such as drinking water, wearing lighter clothing. We also, in terms of those autonomic responses, not only have sweat, but we also have heat dissipating through vasodilation and the opening or recruiting of more pore opening. And then, as previously mentioned, we have behavioral responses as well. That being said, regulation reaches a threshold that it could compensate for. As this heat progressively outweighs our body to metabolically regulate, we're unable to remove this heat as effectively, and we both lose water and salt through our sweat. This combination of factors leads to symptoms of heat exhaustion that we see on our right-hand side, such as the faintness or dizziness, or the nausea and vomiting. This is due to dehydration, effects on the nervous system, and effects on our organ systems. These effects really culminate and spiral once we hit symptoms of a heat stroke. Our organs begin to really feel this weight of the physiological strain, including our cardiovascular system and our kidneys, which can lead to serious damage or even long-term health consequences. This is because both our cardiovascular system and our kidneys have to shunt away blood from the central area to our periphery to allow for this heat dissipation and to cool down our core body temperatures. We can even see brain hypoperfusion, where it receives less oxygen or blood, though it can compensate to an extent, or muscle breakdown in the cases of extreme heat. So, heat stroke, you see really a further dysregulation, such as body temperature above 103 degrees Fahrenheit, or the body no longer able to sweat because the hypothalamus becomes dysregulated. We'll talk about this a little bit more and how heat really affects the brain specifically. So the physiology that we're seeing within the brain is very diverse. We not only have this ability, loss of ability to thermoregulate, but we also have that blood shunting. The blood that was in the center of our bodies perfusing our organs now moves to the periphery because we're able to cool down. This can also decrease blood flow and oxygen to the brain, as well as other organs. Though I do say this with a big asterisk, there have been mixed studies that have shown the ability to compensate by the brain producing its own oxyhemoglobin. This is oxygenated blood. That being said, these compensatory mechanisms take away energy from other necessary tasks and require a higher level of energy to just maintain baseline functioning. Also, as a response to heat, we have a breakdown of the blood-brain barrier. We have higher permeability due to the increase in volume within both fluids and gases in response to heat. And this can also lead to stuff such as pathogen leakage, where we have viruses, bacteria, things that are not good for our brain passing through our nervous system. We'll also see inflammation, which is the body's immune response, or edema, which is a form of fluid trapping and could lead to brain swelling. All of these things will impact neuronal integrity. Not only that, but heats can impact our neuronal firing, our rate, our efficiency, and also how they communicate amongst each other, whether locally or globally within the brain. So, heat has a negative impact on brain physiology, to sum it up. Not only that, but it also relates to decrease in our function. our cognitive and mental functioning, but also our body's ability to create this negative feedback loop to prevent this from happening further. So then we get stuck in a spiral of sorts. Also, when talking about brain health, I really want to quickly talk about serotonin. Serotonin's roles are complex and ubiquitous, especially when talking about psychiatry. We have not just its role in mood and thought and behavior, but it also influences our sleep-wake cycles, our circadian rhythms. Also has a relation to our sensation of pain, our nociception, or even our learning, or in this case, thermoregulation. There is a link between thermoregulation and serotonin, though it's not a direct or necessarily a simple relationship. But serotonin will influence how we perceive the environment. And not only this, but serotonin also responds to heat. There have been a couple of studies that have shown decreased serotonin production in response to excess heat. Because of its role in behavior and a tentatively described relationship between temperature and serotonin production and distribution, it's hypothesized that this neurotransmitter, this chemical in the brain, will account for a wide range of the impacts we're seeing in extreme heat. To break this down a little further, I had mentioned memory, our cognition, a thought process, our mood, our emotional state. I've also mentioned our sleep, not just through serotonin, but heat has a number of consequences to our sleep. And then, as a result of these factors and others, we see both interpersonal violence and violence to the self in the form of suicide or self-harm. So, looking at mood first, I want to point out that we have a lot of these sayings that we see here that, if I could get a quick show of hands, how many of you have seen just one of these sayings? He's so hot-headed, he's hot-tempered, so angry that they make my blood boil, hot under the collar. Okay, so we're all very familiar with these sayings in some way, shape, or form. Seeing a lot of hands. So while heat doesn't affect everyone equally, we still have this constellation of individual experiences that creates a common theme or pattern. We see this once really our threshold for tolerance or comfort has been surpassed by excess heat. Now, with these sayings, it's clear to see how temperature has not just influenced our mood, but so much so our vernacular, our colloquialisms, and our expressions. So these come and reflect from this change in mood when exposed to high temperatures. We're going to get into some of the studies behind some of these mood disturbances. However, we do see a link between heat and increased aggression. That being said, I do want to point out that this isn't always anger. Anger is like a classic association with heat. However, I was researching before this talk and I found that actually one paper coming out of China had looked at a relationship between Google searches or sorry, internet searches for depression and anxiety in response to increased temperatures. They saw that an increased average temperature, which I apologize, I don't have the exact number on hand, did correlated with a 22 up to 22% rise in public searches for depression and anxiety. These are other mood disorders. These are other subjective feelings of our well-being, not related or indirectly related to anger. So we experience things differently. However, heat has really worked its way into our common understanding of mood. Looking at some additional studies, I mentioned anger because some studies have shown this effect in the form of aggression, in the form of our behavior that results from mood. Uh, while the study I show here has a snapshot of the USA statistics, this was done across multiple countries. So this is not specifically a cultural phenomenon where you have an associated or where you have an increase in our environmental temperature being positively correlated with an increase in violent crime. We can also see this with domestic violence. There's further studies that support that as temperature increases, there's increased domestic violence. There's also increased violence against women and children. Again, there are certain groups that are disproportionately impacted by not only the environmental heat, but the human response and our behaviors that are driven by this temperature. We also see this in the form of rape. Again, a positive correlation with temperature. Um, and then we also see this with violent retaliation in sports. Just three individual measures, but that really offer a snapshot of this behavioral response. For example, with this violent retaliation, you'll see pitchers making more aggressive plays, even striking the batter directly. These have been noted not just statistically, but anecdotally as well, and have been supported across multiple studies. Moving beyond violence to others, I do want to touch on violence to self. This is a study snapshot here that kind of jumps off of my earlier study coming out of China, mentioning an impact of heat on mood disorders, or at least perceived well-being. Here we have startlingly, unexpectedly, a 0.7% increase in suicide rates for every 1 degree Celsius over the monthly average temperature when seen in the United States. This increases in Mexico to 2.1% increase per 1 degree Celsius. These might be seemingly small changes, but when we look at these effects over a population, we start to see a trend. And unfortunately, this trend is so directly correlated that there's even been one projection that there might be anywhere in the range of 21,000 more suicides by 2050. This is not just one group, one country. This is across all socioeconomic levels. Not only that, but jumping off on further insights, this author has attributed these increase in suicide rates to um, a number that will actually surpass the number of lives that we can expect to be saved from efforts such as suicide prevention and gun control. That's startling. That's not only showing that we have this direct relationship between heat and suicide rates, harm to self, but moreover, that effects that we're seeing in well-being across other domains of public health are not sufficient when looked at in isolation. One possible hypothesis for this, to just throw in a mechanism of action, has been looked at with the frontal lobe functioning. A possible decrease in that frontal lobe functioning, which kind of controls our executive reasoning and subsequently restrains our amygdala arousal. So we'll look at this further when we look at cognition.
Alex, I'm going to have to ask you to move a little bit more quickly so that there's time for the other speakers, though this is
Perfect.
such rich information.
Can do, certainly. So I think we've covered a lot of this already. We have this impact on cognition, slower response times, reduced attention span, and impaired decision making. This is not just accuracy, but also riskier decision making. I will say, as an asterisk, sometimes slower response time can be actually inversely related, where we have a speed accuracy trade-off. We make less accurate decisions, but at a quicker speed to get out of this discomfort of heat. This can be caused by the cerebral blood flow redistribution, that neuron connectivity or activation, as I previously mentioned, increased stress hormones such as cortisol produced in response to heat, changes in the oxygenation of the brain or having to go through those compensatory measures, or the effect on the sleep-wake cycle. Touching on that real quick, we have measured effects on the sleep-wake cycle in response to heat that can be broken down by its phases. We've seen both reduced slow wave sleep and decreased rapid eye movement or REM sleep. These are responding to the environment, but that also or that also can harm us in how we respond, ultimately through our memory, emotional regulation, and detoxification during the night. We also see more frequent sleep interruptions and increased body movements, especially in the elderly. And as we all know, sleep is important not just for mood and thought, but also other organ functions and can result in increased mortality and morbidity. So just to sum it up once more, individuals feel heat differently. So it's important to look at individual population effects like we're about to do. Thank you very much for your time, and I will pass it along.
Thank you very much. That was incredible material that you covered so well. Shui, we turn it over to you to look at one specific population.
Great. Can y'all hear me and also see my screen clearly, I hope? Yeah, great. Thank you. Thank you so much, everyone. Particularly the Psychiatry Alliance for having me tonight. Yeah, as Robin said, it's 1 a.m. in London, so bear in mind I'm not the most energetic, but very happy to share kind of some work that I've worked on over the past year through my public health thesis at the London School of Hygiene and Tropical Medicine. So just for context, I'm currently a sexual health doctor at Imperial College in London, and I'm very interested in looking at how we can look through research, teaching, and kind of innovative ways to communicate climate change and health. And I'll just go through the slides. Okay. So, how do we define severe mental illness for those of you who might not know? Within the National Health Service in London, in the UK, sorry, we defined it by three conditions of schizophrenia, bipolar, and psychosis. I know various kind of research have defined it differently, but that's the standard NHS definition. And the severe mental illness group is actually highlighted as one of the core priorities to reduce health inequalities within the UK. As we know, they have a kind of reduced life expectancy of up to 15 to 20 years less than the average population. So they're particularly vulnerable. For some background, I'm sure many of you might know, or if you don't know, in 2021, there was a big study by Lee and colleagues looking at how the British Columbia heat dome impacted schizophrenia mortality. And they found that people with schizophrenia were 3 times more likely to die during heat waves. Obviously, that trickled down a lot of kind of public health interventions to kind of make sure that that group is protected. And now we've kind of having to feel and learn more about it within the UK. We have some research that we've done recently as well showing the increased mortality within this group. And right now we're experiencing one of the hottest weathers in May we've ever experienced in the UK. So definitely Alex, when he was sharing lots of the mechanisms, I was definitely feeling it. So thanks for explaining that to me. Which I definitely share with my colleagues as well. And so the research kind of aims at looking at doing a literature review, a policy analysis. I completed some key informant interviews looking at perspectives of different informants, and as well as making sure that I'm making recommendations that is practical to the stakeholders within London, particularly. And in terms of the methods, so the literature review looked at adults with kind of acute effects of heat within high income country contexts. The policy analysis looked at published, publicly available policies within the UK setting addressing heat and severe mental illness. And key informant interviews looked at perceived heat and severe mental illness risk in this group of individuals on the left. As you can see, what their kind of barriers and facilitators to heat resilience planning is, as well as any strategies or interventions that they could recommend to us. Very, very excitingly, I've had the opportunity to do something creative with this research, which I really wanted to kind of encapsulate. And I'm going to share this short film. One sec. So special thanks to the Women's Environmental Network for providing me with funding for this. Um, so just shout please if you can't hear the audio, but I retested it just now, so hopefully you will. Mm, does it not want to do it now? Sorry. Um, let's give it a few moments. Okay. Thank you so much. I hope you were able to see that clearly. Um, just basically like kind of encapsulating the whole of my research, looking at how heat really affects someone with schizophrenia through the hottest day of London. But yeah, so sorry. So just to kind of show you kind of the links that we found from s- the evidence and the key informant interviews that we looked at compiling how extreme heat affects severe mental illness. So as you can see, a lot of the psychosocial things like sleep disruption that was seen in the video, things like being kind of socially isolated, not having insight with not dressing appropriately during the hot weather, maybe having like substandard housing, a very warm room, for example, not having air conditioning, the financial barriers, things like that, can impact someone with schizophrenia or severe mental illness, and make it them more vulnerable to extreme heat. And in terms just to overview with the results, so we looked at 25 articles. As you can see on the table on the right, the odds of mortality in schizophrenics are really high in terms of heat-related illness as well, 38%. Interestingly, for bipolar and mood disorders, there were some studies that showed protective effect of heat during heat-related illness. And you can see things like antipsychotics also increase people's mortality during heat waves. And they also kind of had there were two qualitative studies that looked at how heat looked at were able to the heat actually triggered their physical effects and also their schizophrenic symptoms, as you can see. And there was lots of gaps in knowledge from people with schizophrenia in accessing information and concerns about things like social isolation, having stigma around kind of believing healthcare professionals because of the distrust that they've had over their experiences in the past, which I've tried to portray as much as I can in the video. In terms of the results for policy, there was actually no policies on how heat waves affects severe mental illness to protect this group in the UK, which is obviously concerning. And sorry, the key informant interviews. So in terms of organization wise, there is a kind of good breadth of lack of training. So people, doctors, clinicians, healthcare professionals, they don't know what to do during heat waves. So really important that we look at improving training across healthcare professionals, looking at how we can efficiently disseminate heat health action plans that actually exist within hospitals in the UK, but lots of clinicians don't know about it. Barriers including structural constraints like housing, funding, the usual, as well as communication gap. How are we going to reach every individual at home with struggling with severe mental illness? Can you rely on healthcare professionals to go out in the hot sun on the day itself? Not that's too difficult. So really trying to look at how we can bridge the communication gap within the community. Enablers include research, cross-sector collaboration, and lived experience advocacy. And just a couple more slides towards the end. So some really great examples from colleagues in New York. They have a Be a Buddy program where they have an at-risk register that people can volunteer themselves. And they also train up volunteers, match them with a buddy and those at risk. And they actually check in with them just before or during a heat event, providing that support and also promoting kind of social cohesion as well, which is kind of a win-win for their mental health. Also, British Columbia launched a free portable air conditioning program for those with severe mental illness and low income brackets. So really reducing that financial barrier there. And just to finish up with recommendations. So this is quite UK context, so excuse the jargon a lot here, but essentially really important that we include the severe mental illness group within policy. We need cross-sector collaboration, leveraging on community resilience, community groups, lived experience groups to really inform these policies. How can we work with them to create public health messaging that is strong, that will reach these groups? And things like stigma, making sure that any cool space, things like that is kind of tailored to the needs of those with severe mental illness. And with housing, making sure that we're screening and making sure we're risk assessing what their home environment is like and what they need. Research definitely is always a must and need to gather more in the academic world And I think the really next steps, which London is trying to do, is to fund more pilot projects to build a good case for the kind of UK government to influence and include more kind of strategies to protect this group. So yeah, that's all of my talk. This is just a conference kind of abstract. I've kind of put everything together for my research. I really appreciate you listening, and I'm happy to connect as well through my contacts here.
Thank you very much for that, reminding us the most vulnerable of our patient population and things that we can do in that regard. Thank you very much, and for being with us during the middle of the night in the middle of one of the hottest days of the year so far. Be well.
Thank you.
Bob, you want to step in and tell us about other groups that we should be concerned about in our field? And
Sure. Let me see if I can get my
while he's
slides
bringing
up
that up,
here.
I was particularly put a question mark on the protective effects of bipolar and mood disorders. That rattled my cage.
Okay. People see my slide and hear me okay? Yep. Okay. So I'm going to talk about the effects of heat on various different psychiatric patients that we see, and why all of our patients, or almost all of our patients, are at increased risk when the temperature goes up outside. At first, I want to get back to the study that Shui mentioned, which is a really major study in this area, which looked at the northwestern heat wave of 2021, when temperatures were well above 100 for almost 2 weeks in this part of the country, which was almost unheard of before. And this study looked at the likelihood of dying in various different chronic illnesses. So it looked at different populations of chronic illnesses and what their likelihood of dying was compared to the average population. This vertical line here is average risk of dying during that heat wave. And the mental health conditions that they looked at, first was dementia, which you can see actually had a lower than average risk of dying. And that's probably because most of these patients were in nursing homes or assisted living facilities of some sort where they were in protected environments. So that that actually served as a protective factor. And then we go up these other non-mental health chronic illnesses. You can see that, varying degrees of risk. Then we get to depression, which is a little bit above average risk for patients with depression. Substance use disorder, even more than the average risk. And then the fourth psychiatric condition that they looked at was schizophrenia. And you can see it's way out here, a way outlier of all these other chronic conditions. And as Shui mentioned, these patients had 3 times the average risk of dying during a heat wave. So I just want to talk about schizophrenia a little bit and supplement some of the information that Shui gave us in her excellent presentation. Although schizophrenia affects 1% of the population, 8% of heat-related deaths are in patients with schizophrenia. So you can see that they're way overrepresented. There's something going on with this illness that puts them at tremendous risk. And there's a number of things that are probably involved here, and Shui mentioned these as well, that the illness of psychosis creates confusion or bizarre ideas relating to heat and assistance seeking. Schizophrenia is associated with homelessness and poverty, which means these patients have limited access to air conditioning and reduced access to liquids, which put them at increased risk. There's also impairment in hypothalamic heat regulating mechanisms that Dr. Levine talked about in schizophrenia. And this is independent of antipsychotic medications. There's something about the illness of schizophrenia itself that impairs hypothalamic heat regulation mechanisms. And then the antipsychotic medications are another significant risk because they also impair hypothalamic heat regulating mechanisms through their pharmacologic mechanisms. And many of these patients are on anticholinergic medications to help with extrapyramidal symptoms, and these anticholinergic medications impair sweating. So there's a number of significant factors that probably relate to this increased risk in schizophrenia. And in addition to Shui's great movie that she showed us, there was a really remarkable story in the Washington Post a few years ago, which followed a patient, Stephen Goodwin, who was in Arizona. And it follows the last week of his life before he was found dead of heat stroke in a parking lot in Phoenix. And it's a really dramatic and incisive discussion of this issue. So now I'm going to move on to major depressive disorder. And if you look at hospital emergency room visits for people with primarily major depression, they start going up when the temperature starts getting around 20 degrees centigrade or 75 degrees Fahrenheit. And there's a linear increase that continues as the temperature goes up. Alex also mentioned that rising temperatures are associated with increased suicide rates, and patients with major depressive disorder are the group that's most likely to reflect this. There's also medication issues involved for people with major depression. Antidepressants, the SSRIs and SNRIs, all increase sweating, which can lead to increased dehydration and further heat stroke problems. The tricyclic antidepressants have the opposite effect. They reduce sweating, which leads to increased body temperature. And more major depressive patients are being put on antipsychotics these days as a supplemental medication. And as we previously mentioned, the antipsychotics directly impair hypothalamic heat regulation. So all of these are factors in increased risk in patients with major depressive disorder in heat waves. Patients with bipolar disorder also can be at increased risk. I was unaware of the data that showed there might be a protective factor for this condition, but I don't think all the studies have shown that. But there are certain things about patients with bipolar disorder which put them at increased risk. Increased activity in the manic state causes increased heat production in the body. Again, most of these patients nowadays are on antipsychotic medication, which impairs hypothalamic temperature regulation mechanisms. Lithium, which is probably the single most common used medication for bipolar disorder, increases the risk of dehydration because of increased urination that it causes, which in turn can lead to lithium toxicity. And this patient group also is subjected to the increased suicide risk with increased temperatures. Patients with dementia, as I mentioned before, the ones who are in assisted living situations are actually protected, but those who are living at home are at significantly increased risk because they have decreased awareness of heat because of their dementia. They also have decreased hypothalamic regulatory ability, which is a function of the illness. They become confused about what to do about the heat if they are perceiving it. And again, limited income can be a factor with this group, leading to reduced access to air conditioning and adequate hydration. Patients with ADHD are at some increased risk, again, because of increased activity associated with hyperactivity, increasing body heat production. And the stimulant medications that most of these patients are on also impair hypothalamic heat regulation. It's unfortunate, but almost every medication we use impairs a hypothalamic heat regulation. Stimulants also reduce ability to sweat due to vasoconstriction. And when you're under the influence of a stimulant, you actually have reduced unpleasant sensations of overheating. You're not as aware of the fact that you're getting overheated. Patients with substance use disorders. This group had the second highest rate of death in that study in British Columbia. Number of factors going on for patients with substance use disorders. When you're high, you have reduced perception of being overheated. Again, homelessness and poverty tend to be associated with this condition, which limits air conditioning and liquids. Methamphetamine and MDMA or ecstasy specifically directly interfere with hypothalamic temperature control. Alcohol increases dehydration. And a somewhat troubling statistic is that 18% of all heat-related deaths, these are deaths where heat was determined to be a factor, not necessarily the primary factor, but a factor. 18% of all these deaths involve drug overdoses. What can we do about this? Well, we can educate each other like we're doing tonight. Hopefully get more of this information included in resident training programs and also educate our patients. So I'm going to stop here and turn it back over to Robin.
Thank you very much, Bob. And if Giselle will bring up my slide deck, that would be wonderful, because we are right where Bob said, the what do we do? And I know we're getting close to the end of time. This is really important also, because there are things that we can do. And as healthcare professionals and mental health providers, we need to be able to make changes in provide information and guidelines for surviving heat extremes. So I hope you'll be able to stay for a few minutes more. We've had great talks. Next slide, please. So it is essential that we protect our patients. And what the first thing I want to say is, you don't do it during the middle of an extreme heat wave. You have to prepare, and you have to have conversations ahead of time with patients. This is a infographic that I worked on at UCSF, and it is available on our website. And Giselle also put in the URL in the chat. But it is an infographic that clinicians can use and have in their back pocket for things that they can bring up and talk to patients ahead of time about what to do to protect themselves. There's nothing here that is rocket science. It is all within the scope of reasonable and understandable things. And if I were to do it over again, I'd have some changes. But the most important, as I say, is to make a plan ahead of time. And some of these have been said, but getting out of the heat, it is essential to get out of the heat. Do not let your patients think, oh, it's just a hot day and I'll get through it and it'll be over. This is a deadly threat. They have to get out of the heat. Hydration is essential. One of the things that I would add to this is the cooling down with wet towels. I would add that those ice packs that can be put on the back of the neck, under your armpits or the groin. Backpackers know this and have ice packs that they wear around their necks. So that cooling of showering or wet towels. What you wear matters, being able to not have synthetic clothes, keeping the admonition, never, ever, ever leave a child or a pet in a car. The car becomes an oven quickly. But the most important thing, as I've said, is planning ahead. Next slide. This is available to you, and you can easily download it and use it with patients. It has been translated into Spanish, Chinese, and I'm so excited that a clinic close to where I live just had it translated into Arabic. These are available, as I said, on our website. Next slide, please. Bob has mentioned the medication issues, and this is a really knotty clinical dilemma for us. So he's gone over the medications that are of very significant impact that interfere with thermoregulation, are keeping our patients cool. But what do we do? Heat waves are temporary, short periods of extreme heat during which we are not acclimated. Do we suggest people stop the medications? Are we then going to have secondary psychotic episodes for patients who don't return to their medications? How do we deal with the suspiciousness of taking medications and the longer impacts on the treatments that we are attempting to do with our patients to keep them stable? This is not a simple issue, and I think it deserves a lot more conversation between us in terms of how we recommend and how, but that means I believe we have to be even more vigilant in helping our patients to understand the behavioral things that they can do. Next slide. And the next slide just goes over some of those interventions that we need to pay attention to in the broader community. Shui has already addressed cooling centers. How do we create those as accessible and trusted places? Are there cooling centers that are more accessible to people, like malls and movies that don't bring our patients into these clustered areas? Green spaces in our built environment are essential. How we build our cities and our environments, how we create adequate cooling in the hospitals and clinics and jails. Jails often are some of the hottest places. And my God, I would not want to be a mental health patient in a hospital in Texas, particularly, where there is no cooling in those jails. And then adequate public messaging, I think, has already been addressed. I've gone through this extremely quickly, but I just want to leave time for a little bit of conversation if those of you can stay. And just there are things that we as health professionals can do to impact both our communities and the behavior of our patients. It's incumbent on us to bring it up and talk with them about this. And if we can close off the slides, and anyone able to stay and contribute both in the conversation or questions. And I know some of you will have to leave. You're welcome to turn off your mute. You're welcome to join in.
Um,
I hear somebody. Yes,
yeah.
Ilana?
Yeah, hi everybody. Thanks so much. This was really had a lot of great information. I'm glad I was able to find time to go. What I wanted to say is one thing I tell patients is using frozen fruit
Oh,
or putting
excellent.
fruit, or putting fruit in water and putting to make flavored water so they're not consuming a lot of sugary drinks to get hydrated. Um, and those are some things you could just cut. You don't have to pay expensive for frozen fruit. You could just cut up some fruit and stick it in the freezer.
Lovely, creative. And what you're telling us is you're already bringing it up with patients then. That's step one, and great suggestion. Other thoughts, questions, ideas of any of our speakers? Andres from Arizona is telling us how hot it is in Tucson. Availability of cooling centers and reliable and free public transportation to get them there. Heat island issue is very relevant in our city planning. He does not live in the hottest parts of Arizona. Phoenix is unusually hot, and our patients and homeless get third-degree wounds from the heat of the asphalt and show up in the emergency room with third-degree burns. Other comments, questions, thoughts?
One of my thoughts is that unfortunately in poorer communities, there's less green space. but then people in those communities get worried about creating more green space because then they worry that it'll be gentrified and it'll push them out of the community. It'll become unaffordable. So it's kind of like a catch-22 in low-income communities to add green space sometimes. Or sometimes green space gets destroyed to put in luxury housing, which is happening in New York City. So, that it's a lot of problem with big corporations or gambling casinos and things like that that fight against climate change and against good mental health care and physical health.
Greening our neighborhoods is essential for cooling, and you've just brought up that one solution can create another social problem.
Yeah, I think the city of Philadelphia, I think, stands out in some ways in this regard. They have a program of putting trees on as many streets as possible. And if you want a tree in front of your house, you just call the town and the city and they put it in. So, I think they've taken a big step in this regard. It's not creating an entire green space, but at least it's creating shade along a lot of streets.
Inner cities without tree cover can be 10 degrees hotter in that range than neighboring areas. I know some of you are going to be leaving. I want to thank you for being here, but I'm going to suggest that those who want to stay for the next 10-ish minutes, if there is desire for conversation.
Another thing is public pools.
Oh, yes, you're wonderful. I'm going to have you redo my thing.
Hmm.
Yeah, I think we have really great reflections on kind of ways to help people, like kind of like public health kind of community interventions. I think is really key. I remember like when I interviewed someone who's a psychiatrist in the UK, and she's interested in heat and mental health herself and has done some research, and she was saying how like we don't need to like get like all clinicians to go actually advocate and tell patients about the heat risk. How can we, really utilize the community spaces, like I was at the Lido crossing passing by it the other day in the weekend when it was really hot, and it was full, like massive queue just around the whole Lido. So I think the UK is, the perspective of heat is very positive in the UK. As you can imagine, it's usually very gloomy weather here. So I think, yeah, the perception of positive heat is a big perception within the UK. But how are we gonna, change the narrative? And, those who are particularly vulnerable, like severe mental illness groups, homeless people, are the ones that we really need to target. So I think the UK is having to really rapidly adapt as we speak, which is really interesting in the healthcare setting as well, because we have very old infrastructure. So things like air conditioning is not a very prominent thing we have. But I'm not sure how it is within, I don't know where you are from, but it would be interesting to see how cooling is done within your healthcare facilities. And is there a heat health plan within local kind of facilities that you all work at?
I think we have the same problems and issues that you're facing. Air conditioning is, of course, extraordinarily protective. And you've mentioned, I think, in your talk, the providing of air conditioning is an important safety device, but it is also very expensive. And someone told me a story just the other day of going into a home visit for a patient who had an air conditioner in their window, and it was ghastly hot in this apartment. And that person suggested turning on the air conditioning as a safety. And the person said, I can't afford it. I can't afford the energy. I have to make a choice between that or food. So, once again, those horrific positions to be in. There could be policies, just like paying for the added energy costs during extreme heat, as is done in some communities for extreme cold and paying that added cost for heating during extreme cold. That's a public policy direction.
Yeah, Boston City Hospital has a very interesting program going on now. They put solar panels over the entire roof of the facility, and they're contributing the electricity that's created by those solar panels to the community. They're in one of the poorer communities in Boston, so that's helped people access air conditioning directly through the hospital's efforts, which is really nice.
Yeah.
Um, One thing I also noticed where I work, because I'm on an ACT team, so I go into homes and I walk in the community, is in the summer, people will blast the fire hydrants and sit by the fire hydrants. But, it wastes a lot of water. And I wish fire hydrants had chained to them so people can't steal them, but an optional to switch to a sprinkler cap.
Lovely
Yeah,
ideas. And then the
yeah,
children are out there in the sprinklers.
yeah, and also the adults that are sitting there can get some breeze coming in rather than depleting the water supply. And I just wish they built fire hydrants like that, especially in poor communities.
You could bring that as a policy issue to your local community. Simple solution.
Thank you. I will, I have, yeah, that's, you're right. I will actually bring that up with my city councilwoman. Thank you.
Policies are important. We'll support you in that at CPA.
Okay, thank you.
I want to ask people in the audience, what do you think about this dilemma of medications? Help me with this. I feel it's
I'm on an ACT team. My patients, most of them, they'll get violent if they don't get their medication. So it's you really can't. It's not an option to taper off their medications in warmer weather, especially warmer weather itself can induce increased symptoms. So I don't see that as an option, unfortunately.
Yeah, I agree. I don't think stopping or reducing medications is an appropriate way to address this because you're you're going to have negative results in terms of the mental health symptoms. I think it's education of the patients, that they have to be extra careful when the temperature goes up and make sure they're hydrating and staying cool in any way that they can, and actually encourage them not to go off their medications.
I'd also hesitate to even just change the medications, whether seasonally or in response to a heat wave. These are whether that they're temporary anomalies or looking over a season, the irregularity, and then also changing something that's already shown benefit can really lead to a further period of disruption. So I would hesitate with that as well. I do have to hop off,
oh,
but
I'm going to
thank you
say,
all.
I was just going to say a huge thank you to all of you presenters who did such an incredible job. And the creative ideas that we all need to share with each other because this problem is not going to go away.